such a great trip, and then I had to stay home with 2 years.
Like just different.
So, but I've seen the pictures now, and I'm like,
I think he's just inserting even more.
Yeah, that's fair, yeah. Did you have to like establish who you are?
It's okay if it starts early.
I think they had a great time.
But it's hard.
They just simplified it.
In general, that's fine. People are not going to discuss it.
Yeah, but I look after them.
Yeah. Oh, yeah.
So,
The bonding?
the other one that I
You didn't need more bonding time.
Yeah, have extracurricular activities, get engaged, that's so
We're
hard.
7 seconds in over yours, but you can move it, or you can see it on our YouTube page. Just join if you want. Up to you. I'm not gonna make you attend.
go on with my family.
Can you imagine, like, part of this is like this part of your performance review? You gotta go up there, watch it with me, and you're gonna have to give me a summary. Exactly.
I get 2 1 weeks either. I get 50 where I look after my kids.
So showing up in a video,
So I get 2 1 week around 5.
one person watching. What the hell? That could be me actually.
Essentially run it off to wherever I want to go. So I'm going with my best friends and we're going for drinking. We do it every
Thank
year.
you.
But I'm like, it's safer for all of us if we just go with
Yeah, I forgot I brought lunch. If you sit here, I'll take that.
I'll just keep looking at it. I guess the Wi-Fi died. No, but like I'm plugged in now and I'm logged in. So like I'm offline.
Are you into patrons? I noticed this last week and I meant to
A bit of a delay.
Or is that one of your kids?
Yeah. So no, it isn't the late
Usually
So
we
it's
will
like
take people off from
the wife and we travel. We often take our kids with us, and so I went to China. We walked over my sons, and
The recording too, so we have a.
So it has sentimental.
Yeah, it's handy. So
Next thing I'm doing.
I like that. Yeah, I'm making changes to it because I got to record.
That's something not yet.
I asked her if she wanted to say and what my next girlfriend would be. Oh, cranky.
welcome.
Yes.
So I'd like to take this opportunity to welcome everyone to the first grand rounds of the academic year 2019, and one of the first sessions of format that we're trying out, which is to have the grand rounds be presented at 12 to 1 on the same day that the faculty meeting happens. So welcome, and you'll note that that means we have food for this particular event. So I think this is going to be good. So I would like to start today by doing a land acknowledgement that we are meeting and recreating and learning on the traditional and unceded territories of the Coast Salish peoples, including the Squamish, Musqueam, and Tsleil-Waututh peoples. And the other thing that I would like to say before we start today's rounds is that our next rounds moved with the change of date of the faculty meeting. And so our next rounds will be December the 6th, same time frame, 12 to 1. And our presenter is going to be Jeannie Shoveler. And if you all remember, Jeannie's going to be leaving us. So this is going to be your last chance to be able to interact on an academic level with her. So please put that in your calendars now. Okay. So today's speaker is actually a person who needs no introduction, but I'm going to do it anyway. And so our own Steve Morgan, and a professor of health policy here, and we know that he's done amazing work on access to appropriately prescribed, affordably priced, and equitably financed prescription drugs. And most recently, Steve was named the 2019 Emmett Hall Laureate for career-long contributions to health system equity, fairness, justice, and efficiency. And we're very proud of you for that. So we could frame this as election fatigue is not over yet, work's not done yet. And so our talk today is going to be a prescription for politics, charting a path for national pharmacare. And if you could advance the slide one for me, just to remind people that to get continuing education credit, that's the webpage that you go to. So over to you, Steve.
Thank you so much, and thanks for those of you who are here in person and those of you who are joining us remotely. So we've got about a 30-minute presentation, which in some ways will feel a little bit rushed because it's going to be a presentation in two parts. Part of it will be materials that I've presented many times, and in fact included a couple of times here within the school around the case for universal pharmacare. And then we'll shift gears into talking about the politics and what's going on right now, and I think essentially my sense of what the prospects of reform are. And I'm looking forward to questions, so hopefully we'll get the presentation through in approximately 30 minutes, leaving us with about 20 minutes for questions and answers. So the structure of my prescription for politics is to first of all diagnose the problem in this sector and in this part of the healthcare system. And the problem for Canada is that we are unique in the world insofar as we fail to fulfill an obligation under fundamental human rights, and that obligation is to provide universal access to necessary medicines. Every single high-income country that has achieved universal health coverage offers universal coverage of prescription drugs, except for Canada. And I say this time and time again, and we've been saying this, we kind of coined this line back in 2013 in a report, ironically enough, I published with the C.D. Howe Institute. And that is that if Canadian Medicare is a source of pride for Canadians, then our lack of universal prescription drug coverage should in fact be a source of embarrassment. And I want to explain that in a variety of ways in terms of what are the implications of us not having a system of universal drug coverage. And the first question I'll ask is, what does this mean in terms of us and our capacity to fulfill an obligation which the United Nations has repeatedly declared that all countries have, and that is to ensure when patients are given prescriptions that they are able to fill them. I'm going to use a set of slides that compare international data for Canada and Quebec in isolation, Quebec separately because Quebec nominally has universal prescription drug insurance because by law, every resident of Quebec who is eligible for work-related health benefits must purchase private insurance, and every resident of Quebec that does not qualify for private insurance by way of their workplace must actually purchase a public drug plan through the government by way of paying premiums into it. It is a system of universal coverage, but it is not particularly well integrated into the Medicare system of Quebec. It involves monthly deductibles and co-insurance that are dissimilar to other countries around the world, and it involves premiums and other charges to patients that make it an outlier internationally. However, it is a model that the pharmaceutical and insurance industries, not surprisingly, want Canada to follow, and I'll explain why as we go along. So we've got Quebec and Canada in the middle here as countries that we will look at, or at least systems we will look at. On the left, I'm going to look at universal single-payer public systems for covering medicines and pharmaceuticals together. This includes Australia, New Zealand, Norway, Sweden, and the United Kingdom. It's a convenient sample because these countries participate in the Commonwealth Fund's International Health Policy Survey, and because all of these countries are members of an annual meeting of policymakers that I've been convening for the past 16 years. So I know the systems very well, and if I really need to, I can pick up the phone and talk to the people who manage these systems. So that's one of the reasons for this convenient sample. All of those are single-payer Medicare systems like Canada, but with single-payer pharmacare integrated with it. All of those provide universal coverage of medicines at relatively low co-payments to patients. The United Kingdom is exceptional insofar if you are lucky enough to be from Wales, as some of my family are from, or Scotland or Northern Ireland, no matter what your age or income is, you don't pay anything for any prescription you receive. Residents of England pay nominal prescription co-payments. Their maximum is $15, equivalent of $15 Canadian, but many people are exempted owing to age and particular health needs. The countries on the right in the lighter blue are universal public insurance systems that use the statutory or social insurance structure of financing, where predominantly income-based contributions are pooled centrally and then devolved into multiple different insurance organizations or sickness funds that finance healthcare and pharmaceuticals jointly. And so they're multi-payer systems of financing medicines and healthcare. However, they do achieve universal coverage. They do pool resources centrally typically through government that devolves funding to the insurers, and the co-payments for prescriptions are also very low, on average about $10 to $15 Canadian equivalent per prescription or less. This first slide in terms of access to medicines gives us a sense of how we compare to those other countries based on the Commonwealth Fund's International Health Policy Survey of 2016 that asked all adults whether or not they had skipped a prescription owing to out-of-pocket cost in the year prior to the survey. And about 1 in 10 Canadians reports that they have done so. And in comparison, these weighted averages, the dotted green lines, indicate that about 1 in 20 people in other countries, or maybe even 1 in 30 people in other countries report this. In the United Kingdom, it's 1 person in 50. Reporting access barriers simply because of out-of-pocket costs of medicines. Not surprising that we are much higher than these other countries. What is perhaps surprising but important to note is that Quebec is also like the rest of Canada, and that is because the system in Quebec was literally designed for and by the private insurance industry, and designed with a spirit of having significant patient co-payments as part of the financing scheme. And so Quebec also has very high rates of what we call cost-related non-adherence. Well, what are the implications of this? If Canada were able to bring its level of access up to the levels of these other countries, or put in this slide's terms, bring our level of cost-related barriers down to those other countries, about 2 million Canadians would be filling prescriptions that they're currently foregoing. And the Parliamentary Budget Officer and the Department of Finance have estimated that that accounts for about 60 million foregone prescriptions in Canada every year because of access barriers. The Advisory Council on the Implementation of National Pharmacare, or the Hoskins Council, delivered their final report this June. And they found, according to studies that they commissioned from the University of Montreal, or McGill University, that about 220,000 additional visits to emergency departments are a consequence of access barriers to medicines that could be avoided with universal pharmacare for just 3 categories of disease: diabetes, cardiovascular disease, and chronic airway disease. So they estimated it was about almost 250,000 emergency department visits, nearly 100,000 hospital admissions as a consequence of cost-related access barriers in those 3 categories of pharmaceutical treatment. And they estimated that the cost of that to our healthcare system is about $1.2 billion per year. Perhaps even worse, however, is that research indicates that at a minimum, 300 Canadians die prematurely every single year because of the access barriers created through our patchwork of private and public drug plans that leaves many Canadians without adequate coverage to ensure they can access the treatments they need. That's the equivalent of an airplane of Canadians crashing to the ground every year, and the governments of Canada kind of pondering, should we or should we not do anything? If it was actually an airplane, that plane would be grounded without question, no matter what the cost to society. But what's really kind of perplexing and has bothered me for the last, 23 or so years, is the fact that it isn't the costs that are a barrier to fulfilling the vision of a universal pharmacare program. And in fact, the implications of our fragmented system of private and public drug coverage in an otherwise publicly funded healthcare system are rather staggering. And using exactly the same setup of slide, I just show you those countries in terms of their per capita expenditure on medicines outside of the hospital setting. Canada spends nearly $1,100 per capita on medicines outside the setting, and Quebec spends nearly $1,200 per capita outside the hospital setting. This will probably give you at least an indication as to why the pharmaceutical and insurance industry are keen that Canada adopt the Quebec solution, and that is because it's the only system that we could imagine that costs more than the status quo for Canada. The other countries that we look to, the multi-payer systems of Europe, spend approximately $900 per capita on medicines outside the hospital setting in those systems. And the single-payer systems that we would compare to spend $650 to $700 per capita on average for medicines used outside this hospital setting. Now that might not seem like a lot of money to you until you realize that there are 37 million Canadians, and you multiply these figures by 37 million, and even to bring our level of spending down to Germany, which is the most expensive multi-payer system in the world, or at least in the comparable world, we would find that Canada would save somewhere in the order of about $5 billion every year. If we were to reach the average of those multi-payer markets internationally or in Europe, we would save about $7 billion per year. But Canada isn't a multi-payer healthcare system, and we probably ought not have a multi-payer pharmaceutical system. We should have a single-payer system like they have in Australia, New Zealand, Norway, Sweden, and the United Kingdom. If we were to bring our level of spending on medicines down to those countries' average of about $650 per capita, Canada would save $15 billion every year. That's billion with a B, which makes it real money. $15 billion per year is enough for Canada to purchase every NHL team that is currently playing hockey in the United States and move it to Canada and build it a new arena and do that every single year forever.
That's a great knowledge mobilization. That just
So I mean, Canadians should be pissed off, right? But health policy people should also be miffed about this, because $15 billion per year is enough to double the number of family doctors working in this country and pay every single one of them $350,000 a year in salary every year forever. And the reason we pay so much more for medicines is not because we use more. It is because manufacturers of medicines charge higher prices for the very same drugs in this country as they sell in other countries. So this opportunity cost is truly waste. It is true inefficiency insofar as we are transferring revenue, margins, to manufacturers of medicines abroad, and we're foregoing real opportunities in our healthcare system to deliver real services that might be of real value to Canadians. But the other thing I want to explore is the impact on households and employers in terms of financial protection and the strains associated with medicines costs. Again, using the same kind of figure, we look at OECD data on the the actual dollar value of prescription drug costs that are borne directly by households, either out of pocket or in premiums that are paid for individual prescription drug benefit programs, or by employers for the same things. And then, as you'll see here, is that Canada is conspicuous insofar as we have very little, or I should say very significant amounts of medicines costs that are actually borne by relatively small groups, like employment-related groups, in each of individual employment-related group financing their own expenses, bearing the risks of their own costs for that group mandate, or by households paying considerable amounts out of pocket either because they face co-payments or deductibles that are very common in our drug plans in this country, or because they're uninsured entirely and they're paying for all of their medicines. This implication is really important. Mike Law, myself, and a number of others just a year or so ago published a piece in the Canadian Medical Association Journal, or the Open, CMHA Open, drawing on the Canadian Community Health Survey of 2016, where we found that almost 750,000 Canadians report that they had to forego budget for food in order to pay for their prescription drugs. I mean, this is just staggering to think that in a country like Canada that prides itself so much in access to healthcare on the basis of need, not the ability to pay, that 750,000 households are in fact making these kinds of trade-offs. Do we put food in the refrigerator or medicines in the medicine cabinet? And these are trade-offs that would not exist in the countries that I've been comparing to in these charts. We don't have analogous survey questions in international surveys because frankly no one in international community thinks it's a relevant question about what did you forego in order to fill the prescriptions your family needed. As it relates to employers, there's also a very significant burden. This chart illustrates data from the Patented Medicine Prices Review Board on spending on medicines in Canada that costs more than $10,000 per patient per year. And the data come from 2006 through to 2016. Back in 2006, Canada spent about $1 billion on such very expensive medicines. By 2016, we were spending $7 billion per year on such medicines in our system. This matters significantly if you are the sponsor of a work-related drug benefit program. And the reason is that although only 1 in 100 beneficiaries of private insurance plans in Canada has needs for such extraordinarily expensive treatments, that 1 in 100 patients, that 1 in 100 workers or family members or colleagues, represents 33% of the prescription drug plan expenditures in private drug plans in Canada. And this is, as a consequence, is why an increasing number of employers and unions are basically negotiating away the company health plan, negotiating away the comprehensive coverage for medicines, because frankly, no individual workplace, no individual union has the capacity to both pool the kinds of risks that are associated here, but also to have the clinical, ethical, and economic capacity to manage the costs. So you figure, Canada's got this system where we're spending a huge amount of money on medicines. We're not really delivering very well on access to treatments that Canadians may need, and we're putting an enormous burden on households and every employer in our entire economy. Surely, if we're doing all of that, we must be doing it because the pharmaceutical industry is showering us with investments in our economy, right? You'd think that at least there would be a payoff. Canadians are dying and we are wasting billions of dollars. What's the return on investment? I don't have data for all of the countries in question here, but the Patented Medicine Prices Review Board does report data for Sweden, the United Kingdom, France, Germany, and of course us. And this is percentage of revenues in the pharmaceutical sector that come back to the country in terms of pharmaceutical industry investment in research and development. We're not even really on the chart. These other countries spend 30 to 40% less than we do per capita on medicines, and they get 5 times the amount of research investment back in return. So the punchline to this talk, which I have given so many times over the last decade, is that our system of fragmented private and public drug coverage within an otherwise universally public insurance plan provides worse access to medicines at higher overall costs to society, with greater financial risks and burdens on households and employers, and it attracts less investment from the pharmaceutical industry than virtually every universal public pharmacare system in a comparable country does. It's pretty depressing, really. But there is a glimmer of hope, right? You can turn international experience into insight as to what it is that we should do. And so what is the prescription for Canada? What should we do to remedy that pretty dire situation of actually being outperformed on every relevant metric by virtually every comparator country? Well, the first thing is we kind of go back to the past and we look at the data, and we realize that in fact universal comprehensive public pharmacare for Canada that is essentially adding prescription drugs to our national public health insurance system in this country, has been a recommendation by virtually every commission of inquiry on the healthcare system in Canada dating back to the 1940s. Actually, I don't even have the commissions from the 40s, but certainly from Justice Hall's commission in 1965 all the way through to the Advisory Council on Implementation, the Hoskins Council of this past summer. Every single one of these commissions has recommended, roughly speaking, the same thing. The Hoskins Council, quite frankly, has delivered what is probably the most detailed roadmap, not just about where we ought to get, but in some sense about how Canada gets there. And I want to just go over a couple of the plans or a couple of the specifics of the Hoskins recommendations, because they are important. I say this with a little bit of like, I don't know if I should be saying this because I had worked so hard helping that council with their recommendations. But at the end of the day, I didn't know what was coming out in June when they released their report, and I have never been so happy to see a report that looked so carefully thought out as I did in June when this came out. The Hoskins Council did repeat the recommendation of virtually every other commission in Canada, which is to call for a universal single-payer public system of coverage for medicines on an evidence-based national formulary. So the Hoskins Council recommended that Canada set up a very careful, very transparent, and very rigorous process of determining which medicines have been proven to be safe enough, effective enough, and to represent enough value for money in our public healthcare system to justify universal public coverage of them. And so they've got a number of recommendations about how to go about setting up such a process, and about what kind of representation of the public, the provincial and territorial governments, Indigenous populations, and others need to be part of that process. It's very carefully thought out about developing a true national formulary that is of the medicines that are meritorious, if you will, for universal coverage in our otherwise universal healthcare system. The Hoskins Council also recommended applying best practices in procurement of medicines. In fact, if I was to claim one level of victory in terms of getting an insight into a report that has not been there in the past, that is in past national commissions, it is that universal pharmacare can be a mechanism by which Canada can guarantee the supply of medicines that Canadians need in the event of international shortages. Because when you're buying medicines on behalf of 37 million people, you can tell the supplier of those medicines that you require assurances in order for them to be the supplier in your system. Assurances that the supply will be available to you. Countries around the world do this. Even the US government does it by way of the Veterans Administration in the US, making sure that there's a commitment by both branded and generic manufacturers to put medicines into your market when your market needs them. And it just so happens that by having these kinds of supply contracts, these kinds of negotiated agreements, you can also hammer out some pretty good deals on prices. And that's how those comparator countries get better prices than we do. The other thing the Hoskins Council recommended, which is very kind of controversial in some views, at least in the political sphere, was that this program be ramped up gradually. That we build national pharmacare not overnight, but over a 5-year process of implementation. And I know, and I can tell you without, I don't think telling stories out of school, that this was really grappled with by the council members and by Hoskins himself and by the people advising them about should it be overnight or should it be gradual. And one of the things that I recommended to them is to consider the fact that a comprehensive formulary for Canada would involve about 800 to 1,000 medicines being covered. That is, types of pharmaceuticals, each of which might be available in many different dosage forms. So you're actually talking thousands and thousands of products, but representing about 800 to 1,000 medicine types. Well, if you want to have a best practice supply contract for 800 or 1,000 medicine types, you got a lot of work to do. And so one of the plans of the Hoskins Council was to start with an essential medicines list, the medicines of the greatest value to the public health of Canadians, of a list of medicines about 100 or 200 drugs. And then each year over a 5-year ramp up, add 200 more medicines, iron out 200 more supply contracts. And I was kind of pleased to see the Hoskins Council recommend that, because I think it's pragmatic. It also puts the system in a position to adjust over time as employers and unions adjust to the new reality of government paying for medicines that they historically would have paid for through work-related insurance programs. So there's a very careful ramp-up process, which politically can be dangerous because it appears as though you're being slow and dragging your feet, but there is some pragmatic value to it. And then lastly, the Hoskins Council virtually took a page out of Pharmacare 2020, the report that my research team wrote back just in 2015, around the time of the last election cycle, and that was that the federal government pay all of the incremental public costs of doing this, so that the provinces essentially have nothing to complain about. The provinces are probably going to be spending $10 to $15 billion a year on the medicines that they already cover under existing public programs for older people, for people on social assistance, for people with high-cost drug needs, etc. And so the point of this offer was to be a bit Medicare-like, which is to say to the provinces, if you expand the program to cover every people regardless of their age or income, the federal government will bear that financial cost. And in fact, by doing so, just like with Medicare, the federal government would be putting a lot of money on the table. In fact, it would be putting this much money on the table. According to the Hoskins Council recommendations, when the program is fully implemented, the net cost to provincial governments is $0, because they will otherwise still be spending the money that they're currently spending on their patchwork pharmacare programs, but now they'll just move that budget over to a universal plan. The federal government would in fact be investing $15 billion more into the system. They would in fact be putting $15 billion of federal transfers to the provinces in order to run this program. But we don't want to get caught up in the idea that that means that this will cost Canada $15 billion, because saying that would be to ignore the fact that the private sector would save about $20 to $22 billion in return, in savings, because they're no longer spending the money on private insurance plans, no longer putting as much money out of pocket for the medicines that they are currently having to pay for through private insurance or out of pocket. This modeling was done by the Department of Finance in Ottawa. It's based on very conservative assumptions. It mimics in many ways the modeling that was done by the Parliamentary Budget Officer 2 years earlier. And so you can be sure that this was done in a careful way and in a fiscally kind of conservative way. The net impact for Canada, according to the Hoskins Council, is about a $5 billion per year savings from implementing this kind of program. So you get a system that's really well designed, and it actually delivers net savings to Canadians. So what are the politics? This is the sort of political science part of the talk, and they're pretty easy. To channel Bob Evans, my mentor and a colleague of many of ours over the years. He used to always remind us that every dollar of spending in a healthcare system is a dollar of somebody's income. So when you say you can save $5 billion a year through a program that will improve access to healthcare, some sector of the healthcare system is not hearing about improved access, they're hearing about $5 billion in lost revenue. I tell my colleagues that are working in this file and other groups that I meet with who are advocating for reform that we are facing a $5 billion opponent. When we're scraping together $100 here, maybe $1,000 here, maybe even $10,000 there to try to provide information to the public about why pharmacare is a good idea, there are actors in this debate who are launching $1 million campaigns of marketing information persuasion. And I think actually we're about to see the beginning of a very intense effort by the pharmaceutical and insurance industries to try to scare Canadians, not unlike actually the Clinton-era health reform campaigns against socialized medicine in the United States and against the idea that Americans, although in this case it'll be Canadians, should fear the loss of access to the things that they need most. And I suspect that we will see, because this system is cost savings, which means that it is revenue losing to some stakeholders, we're probably going to see a level of campaigning, if you will. I don't know exactly what word to use, but a political campaign by industry stakeholders like the likes of which Canada may have never seen before. But there's also another politic, and that is the politics of financing. McDonald and Sanger, part of the CCPA and Canadian Center for Tax Fairness, did an analysis last year based in part actually on some work that I had done with Michael Wolfson and the Canadian Medical Association and Journal. And to be honest, Michael and I helped advise them on this particular work. There's a brilliant little bit of simulation work based on Canada's microsimulation systems for taxation and finance, where they kind of said, look, let's look at the world with and without pharmacare, using the data that was available from the Parliamentary Budget Officer in terms of costs and benefits of the system, and break Canada into deciles from poorest to richest households, and then within deciles, break people into winners and losers under a pharmacare system. And this gray bar here represents essentially no cost or benefit in terms of financial terms. Of course, it might improve your access, might improve your financial security, but it won't cost you much more or less to have a public system versus a private system after you take into account the savings from the private side plus minus the new taxes that would be required to pay for this system. The main story here is that overwhelmingly Canadians a significant proportion of Canadians in every income decile benefits from the system, because our system does have gaps in it at every income decile, and if you are a family with significant medicine needs, those gaps hit you in the wallet, and this system will benefit you. But because the system is cost savings, not very many deciles, not very many income groups actually have to pay for all of that savings, because we're actually dividing $5 billion of savings to Canada up, not $20 billion of costs, so to speak. And the punchline here is that really the income decile that gets hit the worst is the top income decile, the richest 10% of Canadians, and arguably actually the richest 2% of Canadians are the group that will bear a true cost of moving from a fragmented, mostly private system into a universal public system. And that group is very powerful in terms of its influence in political circles, and also its ability to fund think tanks to prepare papers and reports that would suggest that pharmacare is a bad idea. Again, we can expect this to happen. It's already had been happening prior to the election. I think the next few months it'll happen a great deal more, with more and more opposition to the plan, in part because very powerful elites will end up having to pay a little bit more under that plan. The other reality is that Canada is a complex federation. This chart here is an illustration of the governments of the federal government and the provinces, color-coded where red is Liberal, blue is Conservative, orange is NDP. So in 2018, many of us had spent a lot of time from 2012 to 2017 trying to get the government to take action on pharmacare, hoping that it might happen in a window where there was alignment. You actually had a Liberal federal government and remarkable alignment of Liberal or progressive governments at the provincial level. I tweeted a photo just the other day of a meeting of health ministers I was at with Eric Hoskins and health ministers from across the country at that time. And the first reply back from the former Deputy Minister of Health from Ontario was, a lot of these faces have changed. The reality today is the Liberals at the federal level face fairly significant opposition at the provincial level in terms of the ideation, the ideals and values of the provincial governments. It will be a much more difficult negotiation now than it might have been 18 months ago or 2 years ago. So can we chart a course? Can we solve this? Can we get past this? I argue we might be able to, and this picture is part of, well, I guess, why this story became a lot more real as of Monday, or as of the election, and that is, it really will depend on whether or not Justin Trudeau wants for him, as an individual, as a political figure in this country, to leave this legacy, the biggest health system legacy of a generation, or does he not? And I put it on purpose that Jerry Butts is in the back of this illustration, because Jerry Butts is probably a peculiar ally to Canadians on this file, and people might not think of that, but Butts actually, his first real job was a research assistant for Alan McEachran when McEachran was a senator. And McEachran helped Lester Pearson implement the Medicare Act for Canada during Pearson's Liberal minority government. So in some sense, Butts actually has seen how this would play out by working with McEachran and preparing what was going to be McEachran's memoirs. The book has not been published, but Butts has all that knowledge. And so it will be interesting to see if this sort of tag team of an individual hoping to leave a legacy perhaps greater than his father's, at least in healthcare, if not nationwide, and an individual who really knows the playbook. Will they come together and make this happen? And frankly, I think if they put their minds to it, it's a done deal. It will happen if they want to. And I think that a minority parliament is the ideal circumstance, ideal situation. It's an ideal if you want to see this happen, and that includes if you want to see it happen and your name happens to be Trudeau. And the reason is that Jagmeet Singh actually represents an amazing opportunity for the Liberals in negotiation with their own cabinet ministers and with the provinces. If the implicit, because we're not having a formal sort of minority government situation where there's a letter of agreement, but if the implicit message is the NDP and the Greens will support the Liberals if and only if they move forward on pharmacare, that actually becomes like a Ulysses Pact for Justin Trudeau and Justin Trudeau's health minister in negotiations with their own cabinet, where there will be cabinet ministers that don't want to go down that path because they have their own individual ideas. But what you can say is, you know what, if we don't do this, the NDP will bring down government. If we don't move forward, they'll bring down government. And anyone who has children knows that it's often really helpful to blame the other parent when trying to enforce rules. And so in a sense, you know, like you can see, you know, Jagmeet is saying use the force, you know, he's giving an enormous amount of power actually to Trudeau and Trudeau's team in political negotiations, both within their party, but also across the country. And I say party, I mean cabinet, because the overwhelming majority of Liberal Party members support universal public pharmacare. People might not know that in 2017, leading up to this federal, 2018, sorry, leading up to this federal election, universal public single-payer pharmacare was the #1 policy resolution coming out of the biennial convention of the Liberal Party of Canada. It beat every other policy resolution. It beat the environment, it beat the economy, it beat Indigenous relations. It was #1 amongst membership of Liberal Party members. So in some sense, actually, Jagmeet Singh is an ally to Trudeau and to the Liberal Party. And at the end of the day, the Liberals and Trudeau get to have the legacy, but in fact they can use this strength of having a kind of a binding pact to make them stronger negotiators with provinces and with their own cabinet. So I'm just about done. The other thing that's fascinating, and this is where I think Eric Hoskins and the council members of the Hoskins Council showed some political genius. Not only was it pragmatic from a logical perspective to gradually grow pharmacare, but Hoskins and the council members decided it would take about a couple of years to get the first formulary ready for implementation. Now, I know my peers who have been advocating for pharmacare really thought this was ridiculous and were upset because that represents delay and the Canadians are going to suffer, Canadians will die, and we will waste money while we wait around. But not only is it probably not a bad idea to get the system right, to develop the formulary process really, really well so that it's the world's best, most transparent, rigorous process for developing a formulary, it also so happens if you implement national pharmacare in 2022, the deck of the provincial premiers may have changed. The question marks here are all provinces that will be having elections just prior to 2022, between now and then. And if you're a Liberal federal government and you want to set up the deck so that the Liberal parties in the provinces have something to campaign on, you pass in 2020 a National Pharmacare Act that takes place in 2022, and you let your Liberal Party equivalents in the provinces campaign on the promise that they will implement. And Canadians will vote for that. And in fact, it puts the Conservative governments in the province in the awkward position of doing something they probably wouldn't have otherwise done. And that is to also commit to implementing at a provincial level. This is strictly, I think, the genius of Eric Hoskins, having been a former Liberal health minister in Ontario, and other advisors within that council. And it's often overlooked, and I think it's quite important. Nevertheless, despite my optimism that in fact there is this window of opportunity, and that there are the pieces on this awkward chessboard seem to be in the right position, mobilization is essential. We need continued mobilization. I was lucky enough to host a meeting with Eric Hoskins and a number of other kind of constituencies that are interested in this, ranging from, this is the Raging Grannies from Victoria, but the CARP, the Canadian Association of Retired Persons, or the body representing people aged 55 and older in Canada, are strong proponents of national pharmacare. They've been at the table talking about how do we mobilize, how do we make sure Canadians understand the advantages. Many of you know that Pharmacare 2020, which is an initiative that I have been a lead on, has sort of morphed into a essentially letter writing campaign now, trying to convince policy elites that the professional, health professions and public policy experts in Canada back this idea. The unions in Canada are behind this and will continue to engage. The Canadian Labour Congress is probably the strongest proponent of universal pharmacare. And we're kind of lucky here in British Columbia that the Surrey Board of Trade, the Chamber of Commerce for Surrey, has for the last 5 or 6 years been a very vocal proponent of universal public pharmacare, because to them and to their members, they see a public pharmacare system making all of their businesses more economically competitive. We need more Surrey Boards of Trades. We need more Anita Huberman, who is the president of the Surrey Board of Trades. We need more people like her across the country to be mobilized. But if we have that, then we continue to be able to have voices that can hopefully drown out what will be a rather intense campaign from those that will lose in that $5 billion equation. So I usually end my talks with this, and I apologize I couldn't get through in 30 minutes. It's taken me 40 so far. But a little bit of optimism, right? And that is, if every other country with universal healthcare system proves that you can do this, that you can save lives, save money, and provide better financial protection to families and your businesses and your economy, well then so can Canada. So, thank you.
Fabulous. So we have a little bit, and I have to emphasize the little bit, of time for questions. And I want to do something slightly different than we've done before. I would like to open the floor for questions first to students, and then I'm going to open the floor to anyone. So are there any students that would like to ask a question as the premier question from this talk? Okay, we'll be thinking of a question then while I open the floor. Questions are now open. Yes, Charlotte.
Hi, Steve. Oops, is it on? Yeah, I found it very helpful to see your analysis of potential for the future, because I'm very worried. Given that you think Jagmeet Singh has a lot of levers here, but also the many other things he's committed to, including climate change, pipeline, that kind of stuff. How prominent is this issue going to be on his radar? And that's my issue. He's promised so very many.
Yeah, so Jagmeet, if you're listening online, I think it's there's no secret. The parties all know this. I've consulted with every major party but the Conservatives. I don't count the People's Party as a major party, and so I've talked to them all. So I tried to sell them all on this idea, both in this election and in 2015. I actually believe that this matters to the Liberals. I think that they want this. I know it matters to the NDP, and I know this matters to the Greens. So actually, if you're talking, and even Elizabeth May had mentioned this just yesterday, that if you think that this is a precarious minority parliament, you've got wrong-headed thinking insofar as This is a unifying legacy deal for those three parties. Pipelines are an issue. Singh has been somewhat clever as to being a little bit non-committal on that, because I think there's got to be some compromise in his view and in the party's view. And that the compromise might be, if we give you pipelines, you're giving us pharmacare. So let's see. I don't think anyone wants to head back to the polls really quickly. And so, again, maybe it's just because I have to feel optimistic, otherwise I'd be drinking way too much. But, you know, I feel like, again, the chess pieces are in place, and I think that those three parties have a common goal here. Yeah.
Steve, a great presentation as always. Thank you for your leadership in terms of the science and for the knowledge mobilization. It's a great model to follow for all of us. I have a two-part question. You kind of heard me raise this theme with you in the past. I was struck today by two stats. One, that about 750,000 Canadians forego food to purchase medication, and I think you said about 10% of Canadians forego medication at a certain point because of cost. Do you have the ability to break those specific data down by age? And I ask that question because, as I've mentioned to you in the past, we absolutely need to build a pharmacare system. The cost savings make a great deal of sense. But there is a potential intergenerational challenge when doing it at this moment when a bunch of baby boomers are about to be retiring and going to a lower period of their income tax payments, but ramping up their consumption of prescription drugs without having prepaid in the way they prepaid for the Canada Public Pension Plan. So it could be, though, that we could resolve that issue if we knew that the people who are disproportionately forgoing their meds actually are younger, not older, because they don't have the coverage.
Yeah, and so we have some data on foregoing medicines by age group. The group that is at greatest risk actually is relatively young workers, because they tend to be in more precarious jobs. I mean, this is a millennial issue because millennials are coming into a workforce with fewer extended health benefits, more precarious jobs, therefore less eligibility. People who are more likely to borrow to pay for medicines are younger Canadians. So I totally agree. I think one of the places we failed in mobilization is with younger Canadians, and I mean, I take some sense of personal responsibility and a sense of regret about that. I think we need to mobilize younger Canadians on this issue. But I would say that the story about people kind of getting older and getting these free drugs under pharmacare, we have to remember that most provinces have relatively generous public drug benefits for older people regardless. So to be honest, what was fascinating to me was to see CARP come on board advocating for universal pharmacare, because they're not doing it for themselves. In Ontario, ODB provides very good coverage for people over 65, and yet the members of CARP in Ontario want this for their children and their grandchildren. So I think I think both narratives are important. I think it's important to recognize that actually older Canadians are going to benefit from public coverage almost regardless. But what we really need to do is focus on, it is younger Canadians. It's Canadians under the age of 40 who are in the worst circumstance in terms of access to medicines and the having to forego other expenses to pay for what they do take.
Love if we get to work on that more. I think there's a real opportunity in school.
Thanks, Steve. Jason here. I just wanted to reflecting on the threadbareness of the provincial health insurance plans, and that this appears to be the low-hanging fruit. Is the next low-hanging fruit, or maybe the high-hanging fruit, long-term care or access to good, high-quality long-term care, the next sort of domino that drops?
Yeah, it's a great question. I mean, that sort of roadmap to our national health insurance system got stalled in the 40s when the provinces and territories couldn't agree to do it all at once with the federal government, so they said policy in stages. And Justice Hall is famous for kind of laying out the roadmap of, we already had hospital insurance by then. He said medical insurance next, then pharmaceutical, home care, and dental care as being the next three essential services. So absolutely, I can see those as coming. And I want to be clear, because I work on other files like access to dental services in Canada. It's not an either or. I think it is actually, we can have both, right? Some of the other ones are harder to tackle, but I think they're part of what we should be striving for as Canadians wishing for a reasonably comprehensive insurance plan.
We've come to the end of our time, and I want to